Well, hey, good morning. And it's great to be here. Thank you, Michael, for the invitation to come. And also, thank you to everyone here for your commitment to improving the health of Louisiana. It's great to be in your presence and in the presence of angels even, so that's even greater. So we are going to talk about the Challenge Grant for Healthier Louisiana. And if I can figure this out, this is just a little bit of an outline. And by the way, I apologize for my voice. Anyone who has a child or a grandchild will know where this came from. Having a 9-month-old grandchild. But the doctor cleared me. I'm no longer contagious. This is just a lingering cough, which Ben tells me it's going to last 3 more weeks, so we'll see. We're going to talk about obesity. Obesity is a disease. It's typically diagnosed with the body mass index. And again, this is just, you take your weight over your height squared, and you have this number, BMI. And in adults, it's fairly easy to diagnose overweight or obesity. If you have a BMI over 25, you'd be considered overweight. If you have a BMI over 30, you'd be considered to have the disease of obesity. Now again, it's not just all about your weight. It's a lot more nowadays. We focus on the health concerns related to overweight and obesity. And it's just one marker to set the stage and say, your BMI is over 30, we should really do a better evaluation clinically because you are at increased risk for cardiovascular disease, diabetes, all-cause mortality. So that's where we stand for adults. In children, it's a little tougher, because children are growing. We need to take into account their changes in height and weight as they grow. So we use age and sex-specific percentiles, and if a child is, whoops, that's not the pointer. Oh, if a child is over the 95th percentile, which was established back in the 1970s, you would be considered, that child would be considered to have obesity. And we've all seen kind of these growth curves. These are built in now into many medical records and electronic medical records. Girls are on the left, boys are on the right. That dark line in the middle is the median. This is how or basically the average, a typical child will develop their BMI with age. Now, if you're above that 85th or 95th percentile, the child would be considered to have overweight or obesity. And again, this is from the 1970s. Back in the day, that meant that 5%, by definition, 5% of kids were above that 95th percentile. If you use that same marker or yardstick today, 20% of our kids are above that 95th percentile. So it's gone up dramatically in the last few decades. So just a little focus on obesity in the United States and in Louisiana. We could talk about health disparities, and we could show some tables and figures and these sorts of things. I think this map really highlights the stark health disparities in obesity in the United States. Now, there's Louisiana, and the colors on the map, the lighter colors like the yellows and the greens, those are states with a lower prevalence of obesity. As you get into the darker colors like the burgundy, that's where we have the highest prevalence. These are states with more than 35% of the population having obesity. So we see that Louisiana is high for both white and African American adults, but it's particularly stark when you split these groups and look at them separately. Now for children, as I just mentioned, back in the day, if you go back to the 1970s, we had a 5% prevalence of obesity in children. Now we're up to, just 20.2%, something like that. So it's climbing and climbing. Back in 2005, you may remember there was all this excitement that the obesity had plateaued, perhaps, in children. Well, that didn't last very long. As you see, there's a little dip, and now it continues to increase. And what I'm going to mention related to COVID is particularly challenging for us. Now, here's the prevalence of childhood obesity in the United States, using a similar map as I showed for adults. But here, the yellow areas on the left are the highest prevalence of obesity, We see Louisiana fits right into that group. Those are children and youth 10 to 17 years of age. And in WIC participants over on the right, we see Louisiana is in that middle category for obesity among very young children. And this is just a graph showing where we stand. We always like these health rankings. We're sixth in the country. Actually, the recent data that just came out, we're down to fourth or fifth in terms of childhood obesity. And you see that that black line is the trend over time in Louisiana, just for the last couple of cycles. And all the other states are basically underneath us there. And again, in childhood obesity, we also see, as Michael mentioned, these social determinants of health play an impact for overweight and obesity. We see parental education on the left, that higher levels of parental education, are associated with a lower prevalence of obesity in children. And on the right-hand side, we look at the race ethnic differences, and we see that African American and Hispanic children have highest prevalence compared to white or Asian children. So we have to think about these root causes of obesity as we begin to address that issue. Now, I just wanted to share with you just a little bit of what's gone on over the last 2 years. This graph from CDC shows the longer-term trend in the increase in BMI on those blue lines that go across in different age groups in children. And you'll see that kind of line drawn where the pandemic began. So these are just different age groups. The youngest age groups are on the top, older age groups are on the bottom. And we see that inflection point in those lines. And essentially what has happened is that increase in obesity we've seen over the years has doubled. The rate of increase has doubled during the pandemic. Now this just shows the initial part of the pandemic. More recent data actually show that that trend has continued. So what has happened in the last 2 years, it's equivalent to about a decade of change. So not only do we have to face what we were dealing with prior to the pandemic in terms of increases in childhood obesity, we're another decade behind all of a sudden. So that's extremely scary for those of us that work with children. And anecdotally, many of the providers in the community say that as well. The children coming in have gained a lot of weight during the pandemic, and also the incidence of type 2 diabetes in children has increased substantially during the pandemic. So it's kind of scary what's gone on. Here's some underlying data from another study, which can kind of tell us maybe why. That kind of darker line which you see going up, that is sedentary behavior measured with accelerometry. And what we see that, again, that line, that kind of box on the right-hand side is the pandemic. So what we see in this sample of children in South Carolina is a quite stark increase in sedentary behavior during the pandemic. And that other line that goes down, that's light activity. So what was happening during the pandemic, kids were increasing their sedentary behavior at the expense of their light physical activity. Now this one is, also concerning. This is what happened with their dietary behaviors. That dark line in the top is the eating of unhealthy foods. And so look at that, it went way up. The other line is the eating of healthy food, and it also went up a little bit. So what this tells us is during the pandemic, the kids were eating more overall. They're eating more unhealthy and healthy foods, but predominantly the unhealthy foods took off. So it's no wonder if kids are being increasingly sedentary and increasing their dietary intake, you'll see that reflected in their obesity. So where to from here? I'm going to take us back just a little bit and talk about the challenge for healthier Louisiana. And this was kind of the impetus for that back in the day, we really understood, 10 years ago back in the day, that any kind of programmatic approach to obesity had to be specific to the region. Each location has unique characteristics. We see that obesity prevention has to be sustainable. It's a long-term goal. You can't just turn BMI around. Obesity is largely intractable once it settles in, so prevention is the key, and it has to be long-term. So these community perspectives were right on point. This is from the Institute of Medicine report. And of course, it said the community efforts to combat obesity were fragmented, and they weren't always based on the best evidence of what worked. It was based on kind of general knowledge from the field. And communities are struggling to determine what to do. They just really didn't know what to do about the problem, and they didn't know which programs to implement. So this is where we came in with the Blue Cross Blue Shield of Louisiana Foundation Challenge for a Healthier Louisiana. This all started back in 2011 with this idea. Oh, 10 minutes? Okay, thank you, Vanna. And so the foundation partnered with Pennington to develop this evidence-based program to address obesity from the community level. And I put on the dates here, 2011 to 2015. This was when the program ran. We developed all the materials and the background in 2011 and issued the RFA in late 2011. And these projects had to be innovative. They had to have multiple partnerships across the state or within the region. And they also had to have matching dollars, which was very important to show commitment from the region. They had to address the specific needs of the community. So they had to be kind of grassroots, coming from the community. And they had to be multiple level. So it couldn't just be an individual intervention. It had to be individual plus community, or a community intervention plus policy. You had to address multiple levels of the socio-ecological model. So here's what happened. It was letters of intent were due in January, and money available was between $250,000 to $1 million over the course of the program, depending on the scope of the study. And there had to be a minimum one-to-one match for this, like I said, to show the investment from the community itself. So here's what happened. We received here, over 100 letters of intent. We hosted workshops to help people develop their applications. We actually received 49 applications, whittled it down to 22, where we invited a panel of experts from across the country. These were obesity scientists. They evaluated all the programs and selected the best ones out of those 22, which were then, we nominated them to the board, and they made the final decision to award 12 of these grants in August of 2012, so just about 10 years ago. So, there were 12 programs that were awarded. They were all across the state. They represented multi-level interventions with multiple partners, with money from Blue Cross and also matching. So we see that in the end, you can see the different regions and where the money went. It went all across the state of Louisiana. The investment from Blue Cross and Blue Shield Foundation was just over $10 million. With the matching funds, it ended up being $27 million invested into this program. Just some of the outcomes from a process point of view. You see lots of produce, lots of new trails, lots of new community gardens, lots of new farmers markets. All these sorts of things that the communities felt were important were developed. Now, we see all the trends going the opposite direction for everything in Louisiana. What we saw in this program was actually good stuff was happening. 5% of the people increased their fruit consumption. We have about 1% here, you could round it off. We're increasing vegetables, we're increasing their physical activity, and a little bit of a decrease in obesity. Now, that decrease in obesity doesn't appear to be very much, but over the course of these years, in the state of Louisiana, obesity was going this way. So just halting that increase in the program, we think, was a very good, successful marker. And also, among participants in the programs across the state, we evaluated this, and if you are a participant in a healthy eating program, there was a 1.9 times increased risk, increased odds, or an increased opportunity that you would improve your consumption of vegetables. So we were getting people to eat more vegetables. On the other hand, if you are exposed to one of the physical activity programs, you had a 2.5 odds of actually meeting and adopting the physical activity guidelines. So, again, we're not going to see big changes in BMI over 2 years, but we are seeing improvements in healthy behaviors. So we believe that was a nice success. So just to summarize, here, we all understand, everyone in this room understands obesity is certainly a major public health challenge. And model programs like the Challenge Grant program are a key component to bending that curve, as Michael says, and addressing obesity from a community perspective. So with that, thank you very much.
So, as Peter noted, this was a program started a decade ago. We saw some research. Right as I was starting, I had the opportunity to work with Peter and team and begin looking at these results. Peter, could you sort of articulate, I know you said it here, but so frequently communities want to address persistent issues, big issues like obesity or otherwise. You all really grounded the initial design of this in best practices you selected based upon results. Can you sort of talk about, obviously you all had done some research beforehand that sort of laid that out, but if I'm a community member that's thinking, well, I want to address obesity in my community, do I call Pennington? How do I sort of get a sense of what those best practices are?
Yeah, we really recommend that community members might partner with academic institutions. And we know there's a lot of academic institutions represented here today, a lot of universities across the state, and tap into that resource to identify these best practices. And what we really relied on was the Institute of Medicine report and reports from the CDC. You can go there and they have reports on the best practices for obesity, physical activity, and diet. So, these are programs with proven success. So many times we'll see people spending millions of dollars on something that's never been tested. It just feels like the right thing to do. People might like it, but it doesn't work. So that was the difference with the Challenge Grant, and that's why the Challenge Grant, as Michael knows, it received national attention because it was actually one of the few programs that was evidence-based. And that's why we had these reviewers come in from all around the country, and they evaluated all of the programs for that, for the evidence of effectiveness. It's just, we all know that, pouring money into something again and again with no demonstrated success is just not the way forward.
And to that point, one of the things Peter and I talked about when I was starting and sort of learning about the work that was underway, there are large-scale grant programs happening across the world, some of them based thoughtfully in design best practices, and some of them not as much. And so when these results came out, to Peter's point, I guess we'd all love to see, obesity dropped in half kind of thing. That's probably not realistic at a community level, but these results are kind of anomalous in the sense of you were saying, Louisiana's obesity trend's been doing this, and what we think we saw is kind of a this. Could you say a bit more there?
Yeah, absolutely. If you look around the world, there's no jurisdiction in the world, no region, no country, no state, no city that's addressed the obesity problem. It's never been done. It just continues to increase despite all of our best efforts. And it's very, very frustrating for someone who works in that area to see that, but that's just the simple truth. And NIH has funded many, many studies. The Healthy Study, for example, they went in and they changed the schools and healthy cafeterias, increasing activity, no change in BMI. We have multi-country studies in Europe that have done the same thing. At the end of 5 years, no change in BMI. So we're fighting the societal forces and the socio-economic status and all the social determinants of health. So that's where we need the grassroots effort. You can't just have someone come in and say, we're going to do this and it's going to work. It's got to be, as Michael says, combined efforts of, academics, clinicians, community members. You need a big team here, for sure.
So we've got about 5 minutes for questions. Folks have questions? David, coming to you.
I believe the number was negative 0.7 in weight loss. Mm-hmm. Did you set a goal that you would try to achieve, or was it purely trying to put the systems in place and then monitor how much weight loss would occur?
Yeah, we didn't set a goal for weight loss. We were focused on those intermediate outcomes, such as changes in diet and physical activity, because the change in obesity per se, that's a longer term outcome that will take years to find out how that will develop.
Yeah. And to just sort of piggyback on that, one of the interesting points we learned both through this process and from the outcomes of the process, when you think about an issue like obesity, that is such a lagging indicator, right? Like it's going to take, at a minimum, a year or two to start getting the data to look at whether it's moving. You've got to have those clear interim measures, and one of the things Pennington pushed us on was healthy eating, physical activity. These are things you can measure in real time versus obesity rates that's much more lagging. And then, frankly, to the point Peter sort of said there were a whole lot of studies, and none of them had actually demonstrated obesity change. And so the thought of setting a goal for something that nobody had ever done before, I think when we saw the results sort of going, dang, we think we actually did something that nobody has ever done before. So I don't know if you want to say anything
No,
more.
absolutely. It was very encouraging to see that.
Thank you. Thank you for the presentation. My question is on obesity. The African American community, and its children especially, are really suffering when it comes to obesity because of not eating healthy and all of the indices that promote obesity.
Mm-hmm.
Do you have satellite programs that collaborate with schools that are actually looking at doing tests of BMI on children, and how can you go about collaborating with where the children are in order to get some results that would be beneficial?
Yeah, that's a great question. We have a very close relationship with the Louisiana Department of Education. And Dr. Kathy Champagne, who many of you may know, she's a registered dietitian and an academic. She is training all of the food service providers in all of the schools about healthy nutrition and doing all these trainings around the state. And she's been doing that for a number of years now. And we're also hosting, with the Department of Education, a webinar on understanding childhood obesity. It's a webinar series. We do it twice a year. And it's just fascinating that we had the dean of the School of Nutrition from Tufts University gave a presentation of a study he recently published in JAMA, the Journal of the American Medical Association, showing the healthiest food that the children typically eat during a day is at school. And they're actually, during school days, they're more active than on weekends or on holidays. So that's very interesting that the healthiest meals children eat on average in the U.S. are at school. It just blows my mind. So that tells us where we need to work. As you say, we need to work with the schools. But on the other side, we definitely need to work with the parents. If the healthiest meal the child's getting is at school, there's something wrong at other places.
Now, we've got time for one or two more questions.
Thanks. Really interesting. We work with school-based health centers, so we see this issue. And just as you talked about type 2 diabetes going up, it's also happening pre-hypertension in adolescents. I mean, we're seeing adult illnesses a lot younger because of obesity. Do you all have any information on the specific programs that were included in the challenge and the outcomes for those specific programs, if people are interested in trying to pull those programs into their areas?
Yes, actually, and Michael, I was on your website the other day going back to the Challenge Grant final report, which I think Ben had a big hand in doing back then. It's a great report, and it outlines all the different programs, what they did, and kind of how we measured it. And there was also, Michael, there was the technical documents from Pennington. I don't know if those are available to the public.
Yeah, they're buried actually down in there if folks want the full technical report, but it gets into what were all of the pieces of each of these programs, to the degree they were effect sizes, what were they, how did they survey. So if anybody wants to replicate this, part of what we worked with Pennington on is you can beg, borrow, steal all of it. There's no pride of authorship. Ultimately, we want good things happening. So certainly all the details, Ben's pulling up some of it. Yeah, our website, yeah. That's free.
Yeah, so my question is, I've noticed that in communities of color, there's been, instead of investing funds, they've been divesting, right? Mm-hmm. So you find that in a lot of these neighborhoods, they don't have access to good food, good healthy food. And in addition to that, the healthy food costs more money. So if you're already low on the totem pole as far as finances are concerned, and then you don't have access to getting healthy food, you're doomed from the beginning. So how do you communicate with municipalities in making sure that the kids after school get nutritional meals that can achieve the goals that we're trying to get?
That's a very good question. And I don't really have a good answer for you. I don't know how to address that question. It's probably a policy issue, wouldn't you say? That we have to address this at the level of the legislature and policy to get real change. But I don't have an answer.
Yes,
So, go ahead.
and to build
Question.
on, I believe what the pastor said, is there a collaborative or collective effort that's included in the report to discuss the connection to children living in poverty and obesity and the economics of that and the economic stability of that, specifically, obviously, in Louisiana, a lot of the red states or southern states where childhood poverty is at record numbers. A lot of young people are living in poverty and the connection to obesity. So is there a collective effort to work with other organizations, specifically around workforce development and exposure to higher paying wages?
I don't know if you want to say anything on that.
Well, I could just hint at something. The Economic Development Agency, the Build Back Better program, that Baton Rouge and New Orleans have come together and put in a major application to that agency to do exactly what you're saying, to address issues of food deserts and poverty and workforce development, because we understand from a health perspective that increasing one of the major things we can do to increase health in the population is to increase the working wage and to increase the good paying jobs in a region. So you could probably just take a map of Louisiana and look at those parishes, and the mean income in those parishes will tell you a whole lot about their health. So we have this grant in, it's almost a $100 million grant. It's being evaluated right now, but it's to establish this kind of medical corridor between Baton Rouge and Louisiana, all along the river parishes, and to address that issue.
And I just add to that, certainly in what we've seen through the Challenge for a Healthier Louisiana, there are certainly some examples of how economic development played into that. But I'd also say our example of this is really try and say, we can move the needle on some of these intractable problems. If you pick an issue that people say, I have no idea what to do about, obesity is really up there. And this is an example of, at a community level, community leaders came together in partnership with others, leveraging best practices, and bent the curve on what seemed like an impossible problem. And that happened here, and that happened in each of the communities that we live in and work in across the state of Louisiana. And that is a powerful thing, because once you know that something's not impossible, then it just becomes a question of how do you do it. And so that was really our aim in starting today. Are there more things we need to do? Is there better ways to connect a whole bunch of other pieces? Yes. And that's part of our hope in all of you being here, is thinking about what goes forward. How do we expand this work and continue to grow this work going forward? So please join me in thanking Dr. Peter Kaczmarczyk. We really appreciate it.
Thank you.